Hi, everybody. My name is Mark Warshofsky. I'm the System Chair for the Heart and Vascular Institute at Nuvance Health. Today, we're very lucky to be joined by a very distinguished group of people to talk about preventative cardiology. And I think that that's a topic that's really relevant to just about everybody. So I want to thank you all for joining me. We've got Dr. Harvey Kramer. Dr. Kramer is a senior cardiologist with Nuvance Health. He practices at Danbury Hospital and Southbury, Connecticut. We are also joined by Dr. Sunny Intwala. Dr. Intwala has a strong interest in preventative cardiology. He practices at the Heart Center at Nuvance Health, and that is located in Poughkeepsie, New York. He is joined by Ann Lucas, who is a nurse practitioner, and she directs the advanced practitioner team at the Heart Center in Poughkeepsie. And Molly Leaden. Molly is a expert in cardiac rehab and is the manager of cardiac rehab in Danbury Hospital and New Milford Hospitals. So thank you again to everyone for joining us. Harvey, I think we'll start with you. As I said, the most senior among us. Harvey, tell us what is preventative cardiology, and we talk about primary and secondary prevention. Tell us more about that.
Well, thank you for the introduction and the backhanded compliment about my seniority. Preventive cardiology is really the notion of preventing something from occurring, or in the case where you've had something that's already occurred, preventing a recurrence of an event. What most of us in primary prevention usually are referring to is for people who don't have known or established cardiovascular disease, trying to identify what their risk for having the disease is, or in some cases, identifying very early disease that they weren't aware that they had. Secondary prevention, on the other hand, is, for example, if somebody has had a heart problem, let's say a heart attack, trying to do all of the appropriate measures to prevent another heart attack. Now, between primary prevention, where you don't have identified heart disease, and secondary prevention, where you know you have heart disease, is this netherland or gray area of what's sometimes referred to as subclinical disease. And that's a very active area of research, and something that we're identifying more and more with some of the new techniques we have, which we can discuss a little bit later. But it's still a form of prevention, because when we detect early disease, we're trying to prevent progression of that and trying to prevent any future events from occurring. So primary prevention, no disease, maybe risk factors, maybe not, preventing any development of disease. Secondary prevention, preventing a recurrence of an event after you've already had an event. And that gray area, subclinical disease, trying to prevent progression of the disease and certainly prevent any overt disease, for example, a heart attack, from occurring under those circumstances.
Thanks. So this topic then really applies to just about all of us.
Well, I hope not us, but it applies to most people.
Yeah.
You're exactly right, because to say it's only for the, if you will, the worried well for primary prevention is unfortunately not the case. And of course, for anybody who's had any identified cardiovascular disease, some form of secondary prevention, lifestyle, perhaps more, certainly will apply to those individuals.
Great. Sunny, I know cholesterol is a big part of prevention, and our doctors, that we see check the cholesterol. There's good cholesterol, bad cholesterol. Tell us about all the good, the bad, the ugly when it comes to cholesterol.
All right, great. So thanks, Mark. So when we check our cholesterol, I think, the guidelines are to get your cholesterol checked once every 5 years with your primary care doctor. Most patients get back their results, and they're looking at a few values there. The first is the good cholesterol, which is your HDL. And that HDL cholesterol, that number can vary from 40 to 90, and that would be considered normal. The higher that number is, 60 and above, is good, and that molecule helps take the deposits of cholesterol, which sit on the blood vessels of the artery, and help filter it out and bring it back to the liver. An important value, an important value that we should all be looking at when we get our cholesterol results is the LDL cholesterol. And that LDL cholesterol is the bad cholesterol. That is what's floating around in our bloodstream that's depositing onto the blood vessels of our heart. And eventually, over time, that's a plaque that builds up that leads to heart disease. And the lower that number is, the better. There's been a lot of debate on what is the best number for this to be. And I tell all my patients, the lower that number is, the better. We know patients that are born with a genetic defect where they don't have LDL. Those folks have been studied and they die from things other than heart disease. They live into their 70s, 80s, 90s, and something else gets them. So, what LDL do I shoot for? Well, if you don't have any medical conditions, I say less than 100. Again, the lower, the better. If you have diabetes, high blood pressure, high cholesterol, if you've had a heart attack before, the lower the better, less than 70. There's been changes in guidelines for my patients that have had heart attacks before, if they've had stents. I like them to be lower than 55, actually. And then on top of that, if you've had a heart attack and your LDL cholesterol is great, there's other tests that you get back from your cholesterol panel. One of those is called non-HDL. What that number is the number of particles that are atherogenic, which means that these particles, again, are all of the bad cholesterol molecules that have the potential to deposit onto the blood vessels of your heart. A good number there to focus on is less than 100. And then if folks have non-HDL less than 100, let's say there's a patient that comes to me that has had a heart attack. I look at their LDL, it's less than 55. I look at their non-HDL, it's less than 100. I then look at the triglyceride level. If it's less than 150, that's great. If not, then there's other medications that I may recommend. All of this on top of exercise and diet. That's 1, 2, and 3 for all my patients.
Great. Thanks, Sonny. One of the big risk factors that we talk about when it comes to causing heart and vascular disease is blood pressure. And I wonder if you could tell us a little bit about how blood pressure, if it's too high, how that affects us, and maybe some things that we can do to lower blood pressure other than medications, because I know a lot of people are reluctant to take medications, but nevertheless want to do something for their blood pressure if it's too high.
Sure. Actually, one of the questions that I get most commonly in clinic is, what does the top number and what does the bottom number mean with blood pressure? And so I explain to people that the top number is the pressure that your heart is actually pumping against to pump the blood as it's trying to move the blood through your arteries. And the bottom number is essentially the pressure in the arteries when the heart is relaxing to fill with blood again. And we used to have cutoffs about 140/90 being a normal blood pressure. In the last few years, they've tightened up the recommendations. And now ideally we'd like the top number to be below 130 and the bottom number to be below 80. A lot of times people come in and they say, okay, my blood pressure is 160. That's not that bad. And then I explain to them, it doesn't seem that bad to you because maybe you've always had high blood pressure. And they say, I'm never going to get to 130. I'll never get in the 120s. And so a little trick that I try to do to help demonstrate to people exactly what that is doing to your heart is to put that cuff, up on your forearm and squeeze it to 160. And you feel that that's really tight. That's what your heart is squeezing against. 60 beats per minute, thousands of beats per day, day after day, week after week, month after month. Over time, that's causing the heart to try to compensate, and it enlarges to try to push and get a little bit more strength to get the blood through that high pressure vessel. Over time, this will cause the heart to enlarge, and it can compensate for a while, but then eventually it will get weak and boggy, and it loses its effectiveness. Ultimately can lead to congestive heart failure.
And it's insidious, right? I mean, patients, it's doing all this damage and people walk around and think they're doing fine.
It's the silent killer.
Yeah.
Yep. So it's really important to stay on top of this and monitor your numbers. If the numbers start to creep up and, you know, maybe you had a blood pressure that was in the 110s when you were 20 years old, and then you hit your 30s and your numbers are now kind of borderline right around that 130 mark, there's steps that people can take that will help to lower your blood pressure without initiating medications. This is things like exercise, cardiovascular exercise, 30 minutes a day, 5 to 7 days a week minimum. Watching sodium in your diet. Sodium is a big factor in this. 1 teaspoon of salt has 2,300 milligrams of sodium in it. So even though people say, I don't add salt to my food, you really need to be paying attention to the labels. When you're buying food, avoid processed foods. Anything with high sodium you want to stay away from. That can make a really big difference with blood pressure control.
Right.
Also, other things people can do is to avoid excessive alcohol, avoid excessive use of non-steroidal anti-inflammatory drugs, maintain a healthy weight, be monitored for sleep apnea, and quit smoking.
Terrific. Thank you. Molly, so we're sending more and more patients for cardiac rehab. I know the indications are expanding. A lot of people, when we send them, don't know what cardiac rehab is. So could you tell us, you know, what is cardiac rehab? What are the different phases? What can a patient expect if they're sent for cardiac rehab?
Sure. So there are 3 phases to the cardiac rehab process. The first we call phase 1. Essentially what we do is we go to the bedside. So a patient that is in the hospital with potentially just chest pain, heart attack, stenting, open heart surgery, any of those parameters, or others included as well. What we do is we sit with them. We introduce ourselves as the cardiac rehab team, and we identify their primary risk factors and discuss those with them. Most of it has been discussed with them by the nurses and the physicians, but what we try to do is take a look at maybe the medications that they're going home on, explaining them in a little bit more detail and what to expect with taking them. If they are currently smoking or trying to quit smoking, we try to provide resources for that. Stress, huge conversation at the bedside these days, especially since March. So diet, exercise, medications, stress reduction, quitting smoking, anything that we can target while we kind of have them held captive here, that conversation can go a long way. We give them information about our outpatient program. So that would be what we call phase 2. Phase 2 is after the fact. So once they've gone home, they've followed up with their physician, they've tweaked the medications that they've been discharged on, the physician will basically say, okay, it's time. What we do at Danbury and Milford hospitals is we have them come in. We have them come in, meet us, see the space. We discuss what's been going on with them since we saw them last. And it's kind of a non-threatening type of situation. And we encourage them to think about exercise now. Medications, since they got discharged, exercise at this point. And typically after a qualifying diagnosis, it is covered by insurance to some extent. And it is for 36 visits with us. So most people come 2 times a week, maybe 3 times a week, depending on who they are. But over the course of the time that we have with them, what we try to do is improve their quality of life, give them the education that they need, build their confidence and their comfort level doing activities of daily living, but also while they're exerting themselves, because many of them are scared. The difference between us and say the YMCA or them exercising on their own is we do have them hooked up to the EKG monitor. So we can say, all right, we're taking a look at your, I call it your plumbing and your electricity. while you're exerting yourself. So we can play the middleman with the physicians about what's going on with them in between their office visits with them. So we try to play the middleman between them and the physicians, let the physicians let them know what's going on with them, because they may be afraid to reach out about, a little bit of this or a little bit of that, or do you think my blood pressure is too high or too low? We can have those conversations with the doctors about those things. The hope is that they lose weight. If they're diabetic, their blood sugars improve. Maybe we can discuss with the doctor reducing or eliminating some of the medications they put on. So our goal is physical and emotional well-being. And for everyone, that's a little bit different. And the starting point is a little bit different. But what I like about my job is everybody gets better. Once they get started in a phase 2 program, it's really tools in their toolbox for what they can do to benefit their life forever. And that's where phase 3 comes in. Phase 3 is what I call forever never amen. It's taking what they've learned over the 12 weeks or the 36 visits in the phase 2 program and continuing those healthy habits. So the secondary prevention piece is we hope that we never see them again. As much as we love them, we hope we never see them again.
Right. Well, that's a terrific summary. Thank you. Harvey, let's go back to you. Let's say I'm your patient and I go into your office and I say to you, Dr. Kramer, what's my risk? What's my risk of having a heart attack like my father did? How do you answer that? How do you tell me what my risk is? What things go into that assessment?
Yeah, that's a very common challenge that we have, whether somebody's already had a problem, what's my risk going forward of another problem, or if they've never had a problem. Sometimes I refer to these people as the worried well, and sometimes they are in fact well, other times not. But it's an issue and a challenge to me that comes up all the time. It starts with the basics, which is a very good thorough history and of course a physical examination and an EKG. And we focus in trying to determine somebody's risk on what we call risk factors. And in fact, there are well over 100 risk factors for developing cardiac disease, but we usually focus just on about 7 because the majority of the risk that people have for developing heart disease, and in heart disease, we're usually talking about primarily coronary disease or hardening of the arteries, and also heart failure, which has the same risk factors, as well as stroke. There are 7 or so of the major risk factors that we dwell on. That's not to say we ignore the others, but the big risk factors, and again, this all comes out in the history, are do you have high blood pressure? If so, how long have you had it and how high is it? Do you have high cholesterol? How high? And is your total cholesterol high? Is your good cholesterol that Sonny spoke about earlier, that's the HDL, is that low or is that high too? Because that could be a modifying factor. How about your weight? We have computers these days that, like it or not, automatically calculate one's body mass index, which is a measure of how much you weigh relative to your height. And it unfortunately affirms the fact that 3/4 of the population is either overweight or obese. So that's another risk factor. Cigarette smoking, which Ann mentioned earlier, is one of the risk factors we look for. Physical activity or the lack of it would be a risk factor, for example. And of course, diabetes mellitus, which is often in its pre-form called impaired fasting glucose or prediabetes, often not known to the patients. We often uncover that. And then the overt form or diabetes mellitus is another one of the major risk factors. And once we have these risk factors, we talk about their effect on cardiovascular health. And of course, each one individually over time can lead to heart and vascular disease. Again, not just heart attacks, but strokes, heart failure, disease of the kidneys, the eyes, of the circulation in the legs. But in the world of preventive cardiology and risk factors, 1 and 1 doesn't equal 2, 1 and 1 equals 3, and 1 and 1 and 1 equals 7 or 8. So these factors are not additive, they're multiplicative. And we can quantitate somebody's risk using these equations that are available online. Patients can actually plug their own numbers in, but they're available through the American Heart Association. And we can quantitate somebody's risk based on their risk factors and plugging them in to this equation. of what the risk of having a heart attack or a stroke, including a fatal heart attack or stroke, over the next 10 years is. And that's not only helpful in terms of deciding who needs to be treated more or less aggressively, because in general, one of the principles of preventive cardiology is the higher one's risk, the more aggressively we should treat them. So if two people have an identical cholesterol, let's suppose it's a little high, if somebody, just for the sake of discussion, has lots of other risk factors or has had a heart attack, we're going to treat the heck out of that cholesterol, where if somebody's 35 years old and has the same cholesterol that's elevated, but everything else is very healthy about that patient, we may not aggressively treat that same number of cholesterol. And the same goes up to a point for blood pressure. So we can quantitate somebody's risk, and the Heart Association tells us that a normal risk is a risk of under 5% of an event, again, heart attack or stroke, over the next 10 years. We begin to think between 5 and 7.5% of how you should adjust lifestyle. And the Heart Association recommends that over 7.5% risk means that your risk is high enough that we need to seriously think about whether additional measures should be taken, for example, going on a cholesterol pill. And what this plays out to in reality is, for example, with men, virtually all men somewhere between 60 and 65 years of age, even if they're very healthy, with the scoring system we use, which in addition to the risk factors I mentioned, two of the biggies that I didn't mention are gender and age. For a man between 60 and 65, even if he's otherwise in great health because of his gender and age, his risk is going to be a little bit elevated. And this comes up all the time because somebody comes in to be evaluated, they have a risk that's, I'll make up a number, 9%, 10%, 11%, and we say, let's talk about whether you should be on a cholesterol pill. And they say, I feel fine, why would I need a cholesterol pill? Right. And we focus on the fact that the cholesterol pill, yes, it will lower cholesterol, but what it will really do is lower your risk of having a future event. And that's what this is all about. These numbers for cholesterol and numbers for blood pressure are just surrogate numbers for risk. And when we lower them, lowering them is just a surrogate marker for decreasing one's risk of having a future event. So the only one that I left out, because unfortunately we talk about modifiable risk factors, your weight, cigarette smoking, cholesterol, et cetera, and unmodifiable risk factors, your gender, your age, and family history. Family history, for the usual risk score we use, there are other scoring systems that do incorporate it, but family history can modify these different evaluations of risk that we use. And if we're on the fence, gee whiz, maybe you shouldn't have a more aggressive treatment. If somebody has a family history of disease of the heart at an earlier age, we might be more inclined to be more aggressive sooner rather than later. Whereas if the patient's family all lived to be 90 and 100, maybe we'll kick the can down the road a little bit for some of those risk factors. So that's really what an assessment of somebody who comes into the office would be about as a starting point. And we can modify that with certain other diagnostic tests, but in the office to begin with, it's about a history and a physical and some simple calculations.
Wow. So assessing the risk is one thing, and that can be done really by plugging numbers in and taking a careful history. But what really is important is how you respond and make the clinical decision making to respond to that risk. And I guess that's why it's really important for patients to see an expert such as yourself or Dr. Intwala to be able to help with those decisions that come with certain risk measurements.
That's right. And I often tell people in an earlier life, I used to sell beer. And one of the many lessons I learned as a beer salesman, and I was fortunate, I was blessed with a very good brand. We won't go into that now, but one of the lessons I learned early in life when I was doing that was that in order to be a successful salesman, you really have to believe in your product. And I can assure you and all of those watching this Zoom meeting tonight that everybody on this call, all of this panel, are really invested and believe heavily in what they're doing. And we get involved and emotional and really put on our sales hat to patients when they come in and try to convince them that it is in their best interest to try to minimize their risk. Again, not just through fancy things to test and through drugs, but also through lifestyle, which you had gotten into with Ann a little bit earlier, with Molly with cardiac rehab. but the full package can really significantly decrease one's risk of initial or future events. And we, as the physicians and healthcare providers, really have to believe what we're selling, because in order to take a patient who feels well and is asymptomatic to do all these things, we're not going to necessarily make them feel any better, because the old saying is it's hard to make an asymptomatic patient feel better, but we are going to make them healthier and decrease their risk in the future of having an event. So we have to be really invested and really buy into what we're selling to our patients to get them to buy into it. Because one of the biggest challenges when we prescribe medicines or lifestyle changes is to get our patients not only initially to agree to do those programs, take the medicines, change their lifestyles, but over time stick with it. It's really difficult for the average patient, even after they've had a heart attack, for example, to stick with the program.
Yep. Well, I know all of your patients are very happy that you've moved on from beer. So keep up the good work. Sonny, I think we'll end with you with just a couple of other questions, which I know have been in the news lately, and that's related to aspirin and the role of aspirin in preventing heart disease and preventing strokes, and who to use it in, and when does the risk of bleeding become too high, and are there other supplements that maybe people might be interested in that have some utility? So if you want to just touch on those things.
Sure. So a lot of folks in the 70s, 80s, 90s, and 2000s have been recommending aspirin for primary prevention, and as Harvey alluded to, that is for folks that have not had their first heart attack or heart event. Folks would be placed on aspirin therapy, and if there are risk calculators called the Framingham risk calculator, if your risk was greater than 10% over 10 years, you'd be put on aspirin therapy. What we've realized with research over the past 5 to 10 years is that aspirin isn't a medication without side effects, and so there have been increased reports of bleeding and adverse events with aspirin therapy. So when I prescribe aspirin for folks, I really, if you've had a heart event, I definitely recommend aspirin therapy. If you haven't had a heart event, especially in my older patients, older than 70 years old, I don't routinely, start aspirin therapy. If you're a little bit younger and you have several risk factors, and you have known a disease or subclinical disease, or have had a family history of heart attacks with an elevated calcium score, in those circumstances, I would add aspirin therapy. But it's not something that I routinely recommend anymore, and I actually have been taking some folks off.
Right. Yeah, I mean, I guess it all goes back to balancing the different risks associated with it, the risk of bleeding, and its benefit in preventing coronary disease and heart attacks. So, again, it takes I think the input from experts such as yourself to help patients manage that decision. I want to thank all of you for joining me today for this really very important discussion, and I think one that's going to be very well received by our audience. I want to really go back to the point that Harvey made, which is, was surrounding the amount of dedication in terms of the staff and the people that we have at Nuvance Health. Patients, I guess if they have questions regarding this topic, they should see their doctor, make an appointment, and discuss it further, but we're here for you. So I want to thank everybody. Have a good afternoon.
Thank you.
Thank you all.
Thank you.